Thank you so much for having me, and thank you everyone for joining us for this 2-hour session. Um, and just full disclosure, my throat is doing this weird thing now, probably because I'm about to present, and that's how it goes. It's for no reason. But yeah, I'm really grateful. And our presentation today is called Recovery Coaching for Pregnant Parenting Participants, What I Wish I Knew. My name is Michelle Kaworis. I use she, her pronouns, and I have been doing this work for a little over a decade as a person who had a baby while using substances and the way I was treated by our healthcare system. I eventually landed in a role where I was a peer doula, and I didn't know what that meant when I signed up for it, but a doctor who I had done a presentation to a bunch of other doctors on stigma and language, heard my story and really encouraged me to join their program, their pilot program. So I did that for 3 years in Chicago, Illinois, on the west side of Chicago. And I had always been invited to do work with people who were pregnant or just had their babies, who had substance use. And I wish I knew so many things at that time, that things that I know now and still learning, that might have helped situations come out in a more positive way. So I think it's really important as recovery coaches and peers that we understand some of the basic things that I wish I knew. So that's why I do this training. I think it's really beneficial, not just for my own professional role had I had this information, but also for all of you, because you never know when you'll come into contact with somebody who might become pregnant or has children at home. And it's not something that I typically see in the training courses I've done, and I've done many throughout the years. So I started my own business because I was invited to share often, and I wanted to set my own rates. I wanted to make sure that my value, as we get invited into spaces, sometimes we are just there as sharing a story or something, and that's not how our roles should be highlighted. It should be valued, respected, and also paid for. So it hasn't been easy, but I also have a full-time job. I'm the prevention director for Sitka Counseling here in Sitka, Alaska, and I'm going to get to my land acknowledgement next. But yeah, I moved here about 2.5 years ago and have been really blown away by the difference of the culture and landscape and barriers and the vast differences between Illinois and Alaska. So we'll talk a little bit more about that. So for my land acknowledgement, I live, work, play, learn, teach, and adventure on beautiful Tlingit Ani in Sitka, Alaska. This is the land of the Tlingit peoples, and they have been stewards of this land since time immemorial. I also recognize the injustices faced by Indigenous peoples, past and current, and I always try to make sure that their voices are not just included in the work that I get to do here, but also uplifted and leading spaces where things that I think sound like a good idea, making sure that it really represents their culture and their beliefs and their values. A land acknowledgement is not just a land acknowledgement, it is the actions behind what we say and what we're doing that really make the difference. So just want to put that out there because I see land acknowledgements all the time, and sometimes it's just a little blurb, and that's not to say like that it's not important. It is important, but it's more important to actually do the things. So and all those pictures I took and videos I took. So it's pretty cool here. So I wanted to start out with some welcome and intention. So again, welcome. Thank you for being here. I want this space to everyone to be open-minded, coming with a curious mind and judgment-free. Some things that I might say you may not agree with, and that's okay. We all have our own thoughts, ideas, opinions, and I value and respect everyone's, even if I disagree with them. Also, we want to make sure that it's respectful, so being kind, not just to others, but also to ourselves, and also making sure that we are self-aware of the safety for ourselves. So if there's something that makes you feel unsafe or makes you feel unease, make sure that you take a moment and step away if you need to, or reach out to supports that you have. And I'm always available too to have conversations if anybody wants to talk further about anything that does come up, or talk about cases or what have you, just to support, because we all support each other in this space, and I just want to make sure that that we do take care of ourselves through this and beyond. And then also taking space and making space. So making sure that if you find yourself sharing a lot, then also making sure that there's space for others. Sometimes people need that little pause in between to get their thought across and then share. So if you're saying a lot, maybe wait for two other people to share and then share again. There's not going to be a lot of interactive, so I'm going to be talking through a lot of it, but I will have some questions throughout this. I packed it full for the full 2 hours, and I will leave some time at the end for questions. I just, there's so much information to be learned, and it's a continuing process for myself. I usually learn a lot more from the people that I do presentations with, that things that I would never read in a book or find online, or just even with our participants, I learned so much from them that I could never know without having those interactions and conversations. So our principles for today's training is remaining open to the many pathways to recovery. On our website, we have an online support group resource that I've built alongside other partners across the US that are accessible online for folks to go to different types of support groups. So AA, NA, Smart Recovery, Recovery Dharma, those are all included, but there's about 60 different types of meetings that and websites that link you to different meetings and connections for folks. And I'm constantly adding to it. So if you do review it and you see, oh, this isn't on there, please send it to me so I can add it, and we can just continue to share that information, because people deserve options. Also, remembering that recovery and healing is self-directed. So making sure that people's autonomy is always at the forefront of our work. And then coaching is a partner, not an expert. We are experts in our own lives, just as the person across from us is an expert in their own lives. And we might have some beliefs or feelings or values or thoughts about their lives, but that's really not our place. It is to empower them to get to break down barriers that are coming up for them in their work. So if anyone would like to come off mute or put in the chat some answers to the question, what do you think are barriers that pregnant people who use substances can face?
Judgment.
Absolutely.
Shame and guilt.
Yes.
Yeah, I was just going to say the same thing, shame, guilt, and judgment, because I too have been a person who used during both my pregnancies. I didn't learn my lesson the first time. I did it again. And, you still, there's guilt, a lot of guilt. And you don't know, there's a lot of shame. So you don't want to ask for help. And you don't know how to go about the help. And then before you know it, 9 months later, there's no way around asking for the help. It's very obvious, and usually CPS or the courts get involved, and it's very scary. So there's a lot of fear.
Fear system involvement, judicial systems. Yes, safety is not always available. Too much shame. How to navigate the CPS and courts. Systemic barriers. Thank you for saying that. And health systems. and fear of losing their child. And just to share something specific here in Alaska is that I live in Sitka. I live on a little island. And if a person becomes pregnant and they have any history or current substance use, they are considered high risk, which means that they have to go to either Anchorage, which is a 3-hour flight north, or Seattle, which is a 2.5-hour flight south. And they have to go 2 weeks to a month prior to the estimated due date, which means that they're usually by themselves, removed from their community and their culture and their practices, and isolated and alone, which is terrifying. So we are trying to amp up the workforce here to make sure that they have protection and supports around them wherever they're at. So, but I'll talk more about that later. Some exciting things that we get to do. Codependency on their partner who may be using. Yes, thank you for sharing that. We forget about the partner a lot of times. So, all right, feel free to keep adding to that. I have to go over some data, and I really want to highlight some things that you all came up with. Yes, resources, specifically around discrimination and racism, because we cannot talk about this population without highlighting that, given the current history, the current, all the things that contribute to the maternal and infant mortality rates. And I'm going to dive in a little bit deeper on this data, but I don't want to spend a lot of time on data because I think it sounds like we all know that there's a lot of barriers and all of those contribute to deaths. So the Maternal Mental Health Leadership Alliance just released the CDC's data analysis of what they've compiled throughout the maternal mortality review committees across all the states. And as you can imagine, that takes a long time. So this data is from 2022, and it was just released last week. But some of the findings include that substance use and mental health are the highest contributors to these deaths. All the things that I'm going to be talking about are available throughout these slides. So you can, if you get the copy of the slides, you can just click on them and go into the article and read it yourself. But I wanted to highlight some of this. Among the pregnancy-related deaths, 45.4% were determined to be suicide, and 51.4% were determined to be unintentional or unknown intent poisoning or overdose. I will also say that data's hard because it's different in every community, state, across different ways that people track that data. Is it the coroner that's tracking it? Is the person that was first on the scene tracking it? So sometimes I think we all know that this is underreported, this information. So I just want to make sure that that is clear as well. But just the findings that they have are pretty devastating. And what are we doing about it? So when we talk about the CDC's findings, there are 4 top takeaways from it was that mental health conditions continue to be the overall leading cause of pregnancy-related deaths, with 216 in 2022 due to mental health conditions, and that more deaths are occurring late in the postpartum year. So after 43 days after birth up into a year postpartum. And more non-Hispanic Black women are dying due to mental health conditions. Hate this, but love that they're calling it out finally. And if, as I do these trainings, I do them in specific states sometimes, and I pull the data in that state before I do a presentation, and I find the same thing over and over and over. And that is racism and discrimination are contributing factors in most of those deaths. And the vast majority, this number really hit me, 85.7% were preventable. It's a lot. Preventable. And again, what are we doing about it? That's my question. So I know that there's a lot of things happening around it, and if you're ever interested in finding out more about what is happening, there are perinatal quality collaboratives across the states. I think all but maybe 4 states have a perinatal quality collaborative or something named similar to that, that do collect this data and do work with the maternal death review system. So if you want to get more information on that, but this one is specific to Illinois, where I'm from, and it shows that substance use disorder was the #1 cause of death in 2021 and 2022. Again, these resources are all available in here if you want to go deeper into it, but it talks about in the next slide how discrimination/racism contributed to 74% of those deaths. So that means that our systems are racist. Our systems are not helpful. They are causing more harm to folks. And here it is in a report from Illinois that they are focusing on it. And I know that they have some toolkits in place that help support this population, but oftentimes when I look through their toolkits, they don't really include substance use and mental health supports. And that is such a crucial piece. Like a lot of times it'll just say they need to go to treatment. And we know sometimes treatment is not an option for folks, especially if they have children, especially if they have jobs, especially if they don't want to be isolated from their families and they need that support. And when we talk about here, the cultural Native practices that I have seen, they need that family unit. Their families are their support systems. So removing them from that is not always helpful. Okay, so how do we play roles in this as recovery coaches? What are our roles? We are motivators and cheerleaders. And what does that mean? That to me means that if a person calls me or comes in for support or is reaching out and trying to make appointments, even if they don't make it to the appointments, if they're calling and canceling the appointments, whatever they're doing, like I am cheerleading every moment of that. I am highlighting them. I am reminding them that, you know, every step forward, even if it doesn't come out to the full goal that they were looking for, like celebrating those moments, because we don't get celebrated, especially when we're pregnant. Pregnant people who use drugs are some of the most discriminated against population, and especially when we're talking about not white pregnant and parenting people. So celebrating everything with them, anything that they're doing in their lives, their goals. We're also their allies and confidants. Some of us are mandated reporters. Some of us have to report certain things, and sometimes it's not always clear what we're required to report. So making sure we understand what that is and making sure we're letting them know that before they even talk to us about anything, so that they are making informed decisions about what they want to share so that they are safe. And then if we are being honest with them about what our roles are, and if they're confiding in us and it's something that might trigger a report or question whether we need to make one or not, we need to let them know that before they say it. And there are different rules in every state around mandated reporting, and If When How is a great resource that I also include in these slides. And they go state by state and outline the basic laws around what healthcare providers are required to report. But I will say that within every state, there are different systems that have their own set of requirements or guidelines that they follow. So in a hospital setting or a doctor's office, they might have different requirements for their staff to report. So I think it's really important to understand all of that and being able to let them know this and be aware of that. These are things I did not know. We are also truth tellers. If a person is continuing to use substances and they are pregnant, letting them know, like, these are the potential outcomes of your decisions, not telling you what to do with your life. It is your own self-directed life, but these are the potential things that could happen. Child protection will probably get involved. And how can we plan for that? How can we make sure that all the things that you want for your baby If you don't want to raise your baby and you want to give your baby up for adoption, like I did with mine, helping them navigate what that looks like. And we're going to talk about a plan of safe care too. So just making sure that we're not sugarcoating stuff and we're being honest, but not in a fearful way. Like matter of fact, these are the things. We're also a role model. Can anybody share what that means to them as a role model? Experience? Go ahead.
Gonna say for me, I figure like if I had to go, I went through some really horrible things. And so I want to use my experience, strength, and hope to share that with the next person so they might not be so scared or fearful or ashamed to reach out for help. If I can approach them and meet them where they are and let them know that I've been there, I've been them, and this is how I got through it. I really wish there had been somebody to speak to me when I was using and I couldn't stop while I was pregnant. So
100%. Me too. And it's hard when you walk into a room to support somebody and you're like, God, I wish I had a me when I was going through this. And it's hard sometimes, but also rewarding at the same time to be able to use our own experiences in those moments. So thanks for that. Someone who can practice what they preach, that they are not alone, lived experience. And we model self and community care, coping skills, and living life with purpose. It would mean sharing my experience if the peer would like to hear, to show recovery is possible, live by example. Mine is to role model you can be healthy and build healthy relationships even after the bad choices. Thank you for all that. Yeah, I think using support resources to help the recovery remove barriers. Do what you say. Love that, Caroline. I think a lot of times we are the only person that they can count on to do what we say we're going to do or be supportive to them. So being consistent, making sure that we are following through on the things that we say too. And also we're human. So being honest about that as well. When I think about role model, I think I make some poor choices still in my almost 10 years of recovery, right? Like I do some stuff that might be questionable to some. I don't need to share all of that with the person that I'm working with if it's not going to help support their goals. So I try to make sure I focus on what they're doing and not bringing so much of myself into it unless it's actually going to be helpful. I see honesty and willingness. It will also speak to community partners on what barriers they are putting in place that they may not realize. Yes, showing them that the mess can become a message. Yes. Another thing, and I'll stop at this because I'll get way behind my time. One of the things that I hear a lot is that people say we want to go upstream and prevention is going upstream and figuring things out and preventing people from falling in. And I'm like, no, prevention is going upstream and find out who's pushing them in and stopping that from happening. So, okay. Problem solver. We are problem solvers in the context of we're not fixing their problems for them, but we're breaking down those barriers, which it sounds like everyone's talking about in the chat too. Resource brokers, connecting them to appropriate resources. I like to vet every resource before I connect somebody to that resource, because if they are stigmatizing or discriminatory or not in line with being supportive and less harmful, then I'm not going to refer them to them. So even like hotlines, I call hotlines before I tell somebody else that they can call a hotline. I will call that hotline and see what kind of support they're going to give them and if they are mandatory reporters. Because if I tell a participant to call a hotline and they call it and they get reported on because I told them, they're never going to call me again. They're never going to come get support from me or trust any part of the system that it probably took them a long time to get to call in the first place. So we are also advocates, so making sure that we are advocating for them in a way that's safe and teaching them how to advocate for themselves in ways that are safe. And I say that because many times I have been in a position where, say, a person just had their baby and the nurse is not being nice and they are discriminatory and they're treating them less than. And I have to leave because my shift is over. So I have to go home. So I'm not necessarily going to say something in that moment to that nurse because I'm leaving and they're going to stay with my patient and it's potentially going to cause more harm. So I have to think about how I can intentionally shift that way the system is by reassuring my participant that I'll be back, number one, and number two, that going to the system itself, the people that host that system or run that system, and have conversations that are meaningful and helpful to maybe talk about why that might be showing up in their work, and also understanding where they're coming from, because I know that nurse probably had seen some stuff with some babies, and it's probably really hard for them to see somebody coming in that has substance use history. Current doesn't matter, just substance use. That label automatically can make people think negatively about a person. So how can we do that safely, not to cause more harm? And like I said, as a coach, you might be the only person that's willing to listen and support them. So remembering that and making it count. All right. I'm assuming everybody here knows what the three-legged stool is. And the only thing that I really want to highlight on this, although they are all important in order for it to stand, right? We know this. But we do treat our people as resources. They have their own capital within how they have lived their life and how they've gotten to the point to where they're with us. But always making sure that we're listening actively and asking great questions that can get us further into the true needs of what they are looking to achieve. But my favorite one is discovering and managing our own stuff. Some of us get into this work because we've experienced things that might have been affecting us through either maybe our parents use substances and now we have a parent in front of us who's using substances. So are we projecting our own stuff onto that situation? And we have to check in with ourselves and make sure that we're not doing that. And if we are doing that and it's kind of skewing how we can work with that person, then making sure that we are referring them to somebody else in those cases. We want to help everyone, but sometimes we are not the best choice for them. And until we can work through some of that, we might just want to look at that because it's real. I know a lot of child protection workers get into the work because they've been a subject of child protection services. And then they get thrown into this role and they have a bias because they're human and they have these beliefs about what it should look like or could have looked like for them and their families. And they bring that on to their work. And sometimes it really negatively can impact a family. And just keeping an open mind around all of that and always self-awareness. So I want to talk about this because I think a lot of us get put into situations in our workspaces where we're not sure, are we really a recovery coach? Are we acting as a clinician? Are we a caseworker? Are we a drug tester? Are we testing everyone for substances? We get thrown into some spaces where our managers don't really even know what a peer or a recovery coach is. So I just want to highlight that. I don't know exactly what to do about it other than to encourage managers to get a little more education around this. So we do provide, and in our business, we provide this education to business owners, managers, people who run treatment programs and such, because sometimes our role is not what we actually signed up for, but we want to be in this space and it's important to us. So I just wanted to highlight that. But I think always at the forefront is our ethical responsibilities. Things like I said, being transparent, making sure people have choices and autonomy. making sure that we have boundaries that are clear. And sometimes that's hard to do when we're asked to do something in a workspace. And when I worked as a peer doula, I had my pregnant and parenting people that I worked with, but in downtime, because it was a pilot program, which I didn't always have a lot of patients at one time, they would ask me to work with anybody that walked through the door, which I was happy to do because I just wanted to do the work. But then that took me away from really working towards improving my scope for supporting the pregnant and parenting people that I was working with. So I never drew that boundary, and I wish I did. Now I wish I did, because now I have a whole other group of people that I'm working with, and that all takes time. There's so many things that we have to work through. So it's very time consuming, and it took away a lot of what I wanted to do with the population that I was there to serve. So let me just do. And then our language, strength-based, person-first, healing-oriented language is so important in this space. And I do stigma and language trainings at our local hospital, our only hospital here in Sitka. And I think that is like the greatest way to open the door for having people understand how to even speak about us or to us or for us, because it happens all the time. I'll be in a room with a bunch of people who work in the helping field, and then they'll start talking about people who use drugs in derogatory terms. And I'm like, hold on, I'm over here. Can we have a conversation about this? Because it really triggers me as a person with lived experience. So I can only imagine what it does to their clients and patients. And so I use those as learning experiences for people. So when we are working with people, just letting them know that we're here to support their goals and finding out what matters to them the most right now. We might have a sense of urgency for something that has nothing to do with their goals. So especially when there's a baby involved, we have, as humans, we want to protect babies, but also like we have to remember that the family needs support in order to make sure that the children are safe. And I will say that in child protection and foster care system, a lot of times that isn't the safest place for a child. And I think that if you talk to child protection workers, they will agree. I work with them all the time. Actually, in Alaska, they're getting sued here because of how not helpful it is and harmful it is, and children being kept in institutions for up to a year because there's no placement for them, which is, yeah, it's a whole thing. So recovery coaching within these systems that we're talking about include healthcare, many levels, which some of you mentioned in the chat, of different ways that people are discriminated against or stigmatized or dehumanized lives in our healthcare system. I was traumatized by our healthcare system, and I think when we look at why that is and how that is, whether it's just the views that people that are projected out there into our spaces, whether it's social media and how people are talked about, it perpetuates through our healthcare system, which is supposed to be healthcare and oftentimes is harmful. So how can we fix that and change it and make sure that the people that we're working with are safe in those spaces? And that could be going with them to their appointments, advocating in a safe way for them, having conversations, and educating staff from the person at the front desk all the way to the checkout person. There's many moments within a system where a person could get a call made against them. And that could be just anybody's beliefs about what, if they look like they're under the influence, somebody could call just because of that. And that's not always, in every state, that's not a requirement to make a report. Using drugs does not make you incapable of parenting. So understanding your laws in your state is really important too. So then child welfare, like I said, I've worked with a lot of child welfare employees and staff. I just got invited to do a presentation and training for the Alaska, it's OCS here, the Office of Children's Services, which I'm really excited about, and also understanding that they're overworked, they're understaffed, their caseloads are ridiculously high, and that puts a lot of barriers just on this work period for them, for the families that they're working with, and it really often turns into not great situations and outcomes, as evidenced by us suing our foster care system here in Alaska. And that happens not just here, it happens all across. So I think having had worked with them over the past 4 years, I have learned so much about them and their roles and how hard it is for them to make choices that go against everything of their being, their values, their beliefs, their ethics, because they are required because of something that's written on a piece of paper to take a child from a family. And that's hard. I couldn't do that. I could never do that role. So how can we support them and educate them around substance use, mental health, de-escalation, better options and opportunities for people to heal, except for the cookie cutter, treatment, inpatient treatments. That's what I hear all the time. They need to go to treatment. Well, there is no treatment for pregnant people. So where are they going to go to treatment? And if they can't get into treatment, you're considering them non-compliant. So how can we work together to break down that barrier and still get them the support that they deserve? And then legal. A lot of the parents that I work with have legal situations that they're dealing with. So how can we support them through that? Do we know about, in Illinois, there's Prairie State Legal that sometimes could help with some situations, but not all. There's, If When How also is a group of advocates and lawyers that help people with their own reproductive justice. There is the reproductive justice program. So find out what resources are available and get them connected with those if they need it. And then also learning about some of that if it is within your bandwidth to do so, because if I knew what human rights and parental rights were to the point of what I know now, and I'm not saying I didn't help the people that I worked with 10 years ago, but I probably could have helped them more, and things might have looked vastly different. So not dissing on myself for what I didn't know. I did the best I could with what I knew, but I wish I knew more. So then making sure that we're coaching within those systems, not against them. And I know sometimes that's really hard to do when we see the devastation that can be caused by those systems. But we're going to get a lot further if we actually come up with plans together to work on these situations. And I know that's not possible everywhere. I understand discrimination, racism is very real. And I understand that I have some privilege around being able to do that in certain spaces just based on color. I get that. So getting supports around that I'm an ally. We are allies and we want the best for outcomes for folks. So always supporting the participant's voice and choice, even if we don't agree with it. So helping them prepare for appointments is really important, understanding what might happen and making sure that they're clear on that, supporting self-advocacy, and then asking them, like we were just talking about, like, what do you want them to understand about our own recoveries? When is sharing appropriate? When is it not? What is helpful versus harmful? Are we just wanting to talk about what we've done? If that's the case and it's not really helpful, then maybe we want to find our own person to talk to about that outside of that space. And I've done that a lot. I will be the first to admit I've done that a lot because I want to relate so badly that I'll share things that probably weren't really helpful. So just checking in with yourself and understanding why you might be sharing something. And I just lost my slides. Hold on 1 second, please.
We can still see them, Michelle.
Yeah, but I couldn't advance. So
Oh.
we're gonna try this again. I'm in Alaska. Our Wi-Fi is not great. So we'll just say that, but it's been doing me good. So I'm trying not to talk too much about
Do what you got to do.
it.
Crazier things have happened.
I'm just glad we have Wi-Fi today, to be honest. Okay. All right. Let me get back to the slide where I was, and we could go. I did it again. Okay, well, we're going to share this way because it seems to be working.
Whatever works, right?
Oh, so sorry. You're doing so good. All right, so moving on. You guys can see my screen okay? So recovery across pregnancy and parenting stages. And it's making me nervous. So some things that we can do during each stage, and from the moment that we find out that a person is pregnant, some of the things that we can do is provide harm reduction resources and making sure that they have access to supports. And like I said, if that's not us, then making sure that they have access to birth workers or peer doulas or midwives, somebody that can actually help support them through this. Because it's really important, and it's so important that they make their appointments. That is prevention, making sure that they are getting access to the care that they and their babies deserve, even though we know it's scary and we know that there's so many barriers to that. But there's so many things that we can do. And even if that's just listening and trying to navigate some resources that they might need, food, clothing, whatever it may be. I didn't know until I filed for adoption family to adopt my son. I did not know that they would have paid for my rent, my housing, my rent, my food, my clothing, and some amenities. And I didn't I didn't sign up for it until I was 8 months pregnant because I was so scared and didn't know what to do. So had I known that information before, it might have helped me shift some things in my life if I had that support system. So always making sure that we're building support networks with them, building their personal capital, which I'll talk about in a minute. And then during the birth, if they invite us to that space, which sometimes you might be the only person they trust, then knowing like just simple things to do with them to help them feel calm and at ease and advocate for them, knowing that if they are saying something's wrong, something's probably wrong. We are the experts of our own bodies and our own feelings and thoughts. And if we say something's wrong, something's probably wrong. So advocating for them. There's so much mortality and morbidity among pregnant people because doctors refuse to listen, or nurses or healthcare providers refuse to listen because once they find out that they have a substance use history or current, they discredit everything that they have to say. And that's really important to know and be that person to help them make sure that they voice their concerns. Preventable 70 or 87 ridiculous amount percent preventable deaths, right? And then postpartum, oftentimes when people have their baby, once the baby's out, they lose contact to all the resources that they had. And as we read earlier in the data, most of the overdoses, suicides happen 43 days to a year after baby's born. And especially if the baby's taken from them or if they lose their children, that is so difficult to come to terms with as a parent, or giving them up for adoption. I can't tell you, that was the hardest thing I've ever done in my life, and also the most important thing I've ever done in my life. And then my healing and wellness, but that making that decision to give up my child or having a child removed from you is the hardest thing for a lot of people. So making sure that we're amping up our support systems in those times. There's a lot of mental health things that come up because bodies are changing as we are going through the pregnancy and birth and postpartum. So there's a lot of studies on different types of mental health issues that come up for pregnant people. So making sure they have access to the resources and listening to them and validating and connecting them with resources. And then early parenting. I work with a lot of family support systems. So UCAN out of Portland, they do family support. They go to the homes, they support the family as a whole. And one of the main questions that they ask me is how do they address it when they have concerns about the child, like the child's not accelerating in the way that they think they should, or they're not hitting their milestones. So one of the things that I really love sharing is the CDC has a milestone tracker, and it is a app that the parent can put on their phone, and it tells them like where baby should be in 3 months. It doesn't say that all babies, it says most babies should be in 3 months. And that's really important to decipher because we don't want them beating themselves up because baby's not rolling over at a certain point. We just want to make sure that if it is a concern that they're tracking it and they're talking to their doctors about it. And so it's a really great resource. They have printable documents online where the parents can check off where they're at. So just how can we support them in that? Oh, I'm like, I don't think I just underlined that. So you did that. So just finding out like what kind of support feels the most helpful in each stage of their pregnancy and birthing, postpartum. All right, so skills in action, active listening, all these things that we've been taught or continuously learning, motivational interviewing, all helpful skills to have. Strength-based coaching, which I'm going to talk more about, and then warm handoffs, making sure that we are connecting them to appropriate resources that are not harmful. And then not saying you should. I know I said you should a couple of times in this, and I try not to say that. I try not to shit on myself or my participants, but making sure we're replacing that with what feels like the next step for you to take. And if they have nothing, then offering options, knowing what those options are, all the different types of support groups that are out there. There's different platforms if people are on social media where they can connect with like similar groups of people that might be going through similar things. We used to host a support group for our patients at the hospital where I worked, and we had some that were justice involved and some that weren't, and they both on both ends felt like they couldn't relate with each other, so we broke that out into 2 separate groups, and it worked. It's amazing group that they do now. So stigma, bias, and trauma, healing-informed recovery coaching. I don't like to use the word trauma-informed anymore. I like healing-informed. It's more strength-based to me. But, you know, trauma's a pretty popular word these days. So just thinking about this, making sure that safety is always number one. If a person doesn't feel safe to come for help, they're not going to come for help. And that means being honest and transparent about our requirements, or if we're not mandated reporters and there's something that might trigger for us to make a call as not a mandated reporter, but just as a human, letting them know what those things are, and then also giving them choices and empowering them. Some of the things that I really, really recommend as coaches is that we reflect constantly on where we're at in our work, no matter who we're working with, on what assumptions do you bring to your work? What are things that you bring in, experiences that you've been through, outcomes that you've seen, but can't say that happens all the time, right? We all have different ways that we get places. We have different resources. We have different capital. And thinking about how that might impact your coaching, how would that impact how you do respond to something somebody says. Some of us, our facial expressions tell everything. Are we checking ourselves in those moments? Are we making sure that we're, I had a therapist, and when I told her about my history of sex work, she was just like, like shocked. And I was like, oh, okay, well, this is an educating moment. I can educate her on some things. And I did. And we have a beautiful friendship now because I'm not her patient anymore, but constantly learning. We're all constantly learning things. So making sure that we are checking in with our own judgments and our own beliefs and our own values, and making sure that we're safe for the person that we're working with, and if we're not, knowing who to refer them to. Okay, one of my favorite things to talk about is personal capital, aka recovery capital. Not everybody that we work with identifies as a person in recovery, and people bring so much personal capital into every space that they are in. So we do one specifically for pregnancy, postpartum, and parenting people, even though this can apply to really anybody. But when we talk about that, it is personal capital is the same thing as recovery capital, just not labeled that, right? So lived experiences, their support systems. When we talk about their skills and their strengths, are they advocating for themselves or their children? Are they problem solving and adapting to situations that are coming up? Are they, is their emotional intelligence or their self-awareness apparent? Are they setting boundaries with family members or people in their lives? And are they persistent and moving forward with whatever their goals are? So those are all skills and strengths that people carry. And talking about support systems, do they have people around them? It might not be the typical family or friend, but it could be somebody that they met at the clinic. It could be a doctor, a nurse. It could be a social worker, the housing rep, whoever it might be, the shelter that they go to, a food pantry. Anybody is considered that's supporting them and helping them get the basic needs that they have is considered a support, and highlighting that for them. And under beliefs and motivation could be their different cultural practices, which can also fall under support systems. I know here for the indigenous populations, aunties are really huge, respectful, supportive systems that people count on here, or elders, and making sure that they know that these are all strengths that exist for them and that they can bring to the table to try to build up their own confidence and empowerment. Their resourcefulness. So how have they navigated getting food? How have they navigated getting from point A to point B? They've gotten to you. How did they navigate all that? What does that look like? So what are their different resources that they already know of? I got more resources from the people I worked with than I did trying to Google stuff. So people are like, oh, I was at this place and this is the care I received. Okay, let me grab that and share that with our other participants who could benefit from those resources. Also their parental capacities or capabilities, even if they're still working on those. Are they going to parenting classes? Are they interested in parenting classes? Those are all strength-based things that we can be looking at with them and reminding them of. And why this all matters is because it helps us name them, honor those strengths, and build on those personal capital, making sure that we're shifting that from deficits to strengths. If we're constantly talking about the things that are wrong, it's really hard and overwhelming to move forward. And if we're building on the things that are going right, that builds momentum, and it makes it more rewarding for everyone. And this also helps them feel seen, heard, respected, helps them reconnect with their own power. We don't get a lot of that, especially if we're pregnant. We're isolated, we are stigmatized, we are ousted, we are often using alone. I use alone all the time. Even though all my friends were using, I used by myself because I had that shame and stigma and internalized all these things that I was told to believe about myself that aren't true. I'm human and I needed support, not surveillance. So also recognizing all the things that they are doing right. It's really important for us to give them a high five on the things that are going good to keep that momentum going and building that trust. So our company, we built this parental strengths and needs assessment, which, like I said earlier, a lot of us sit in different roles other than what we thought a peer or recovery coach is. And I was a case manager for a while, even though I was I was our residential program manager, but I ended up being a case manager. So I found these resources and then I expanded on them because I think it's really important that for this population that I highlight some of the parental considerations for people when it comes to trying to figure out their entire life domains. So this is also accessible to everyone, and it just goes through different things like psychological and emotional well-being. So what are some of their strengths, things to consider, like if they have a diagnosis, how they're functioning, their insight, judgment, memory. And then some parental considerations could be what's the support system for the children? What is their ability to support emotional development of their children? Do they need help in that? And then some harm reduction considerations. So is there non-coercive access to mental health care? Do they have to, like, is there something outside of being separated from their family for 28 days to 6 months that they can do in their lives to increase their health and wellness? And then this is just an example, and I'm sorry if it's really small, but like I said, you'll have access to this, but the strengths that you might write for them, you want to build on their strengths. So they have self-awareness, emotional regulation skills, ability to express and process emotions, like building on those things is really important. And you could be the only one that's looking at those things. So highlighting that, and then their needs. This gives us a good place to figure out where we want to go with what they need and what resources we want to get them. And if we don't have them, we're reaching out to the perinatal quality collaboratives to see what resources they have or other people who do this work, peers, doulas, maternal health workers. So it covers, the second one is the safety and crisis management. Obviously, that's going to be really important. We want to assess where they're at. Like right now, is there anything that we need to really focus on for them that is making sure that they're safe and their children are safe and their families are safe? So I won't go too far into this for time, but if we do have time at the end, I'm happy to go through any of these into a little deeper. So the whole focus of that worksheet is to support their goals. So making sure that we're supporting them in what they're wanting out of their work with us, and then also preparing them for system interactions like child welfare or legal or healthcare and what that might look like. Also giving them resources, warm handoffs, connecting them with care, and then making sure it's flexible and ongoing. It could change. We could cross some stuff off once we've taken care of the needs and they're achieved. And constantly, like, new things come up, right? We know that happens all the time. So like I said, this will be available for you, and it's developed with the participant, not for them. So we want to make sure they're an active member in this process. So there's a downloadable PDF and then a fillable form here also. So it's blank seat.
So Michelle, hey, real quick, sorry to interrupt. I can share this link to the slideshow with everyone because I'll do it right now and put it in the chat.
Absolutely.
Cool.
Absolutely.
I'm going to do that, guys. Keep an eye on the chat. Thank you.
Yeah. So yeah, this all promotes autonomy, safety, and non-judgmental supports. And one of my other favorite, I have a lot of favorite things. This is like my favorite topic to talk about pregnant people who use drugs because so much good is happening, but at the same time, it's a great opportunity to do better. So there's a pregnancy and substance use toolkit. Has anybody heard of this? No.
No.
So the Academy of Perinatal Harm Reduction and the National Harm Reduction Coalition had partnered to come up with this. The Academy of Perinatal Harm Reduction, Joelle Puccio, who is amazing, has created this, and it is, I'll tell you what it is. It covers all the things to guide either patients or people that work with them, people who are using drugs that are pregnant, on different real facts about different substance use during pregnancy. And this is nothing to say that, oh, it's good to use drugs. That is not what this is about. It is about the real facts and proven data around what substances are. If anybody remembers the crack baby era, that was really harmful to people who are pregnant who use drugs. And it was unfounded by the person that announced it to begin with. Because, you know, it just was. If you haven't seen the videos on the history of that, I highly recommend to look it up because it did a lot of damage, and rebutting that didn't do much. So we are still living in a system where people believe that if you are pregnant using drugs, you're a horrible, horrible person. You don't care about your baby. That is not true. I cared about my baby. I just needed support. So this guide will go over some of the patient rights, quality perinatal care, evidence-based harm reduction strategies across different substances, including what some of the effects are around breastfeeding and substance use during pregnancy. And it is all about autonomy, informed consent, whole person, family-centered support. It has a how to use these materials in the beginning. It talks about different substances. This is the first one was created in New York, and when I worked in Illinois, we brought it to PCC, which is where I was working, and had it customized specific to Illinois resources. There's one now in Michigan, Wisconsin, South Africa, Myanmar. Like it is growing, and now we're building one in Alaska, but we are not calling it harm reduction in the title for obvious reasons. So, but it's going to be more directed to the participant themselves, not necessarily the healthcare providers, although we will teach healthcare providers how to implement that with the person, hence learning about the rights and people's autonomy. So we did dedicate this to Tatiana, who I ended up replacing her role as a peer doula. I was supposed to work with her, and she passed from an overdose the week before I started. So we dedicated ours to her. So then it just goes through, there's different worksheets in here, kind of like a plan of safe care, which I'm going to talk about more, but highly recommend that you check it out and share it. Yes, it's 154 pages, but it is 154 pages of good information that is really trauma-informed, strength-based, and just really helpful for people that we work with that either use or have history of use. And I keep saying that because it affects you. You could be in recovery for 2-3 years and become pregnant, and it all comes back on you if the healthcare provider is not versed on what recovery looks like. So now, there's a lot of different plan of safe cares out there in different states have their own. One of our favorites is the Michigan's plan of safe care, and I'll tell you why in a second. But it goes over different things like family, personal and family strengths. Usually a plan of safe care is used once a case has been made with a participant. So if a person is, somebody calls DCFS on them, then DCFS or Child Protection will get involved and has to build a plan of safe care. And a plan of safe care is supposed to be an outline of what they're doing, what they need to be doing, resources that they're providing to them. Like that is the whole plan of it to improve the outcomes. But if we can get a plan of safe care before Child Protection gets involved, then we could prevent a lot of this as well. And when Child Protection gets involved, they have this resource of all the things that they've been doing and their understanding of what is required of them as parents to go and advocate for themselves in that space. So this one is, like I said, my favorite. Are you guys seeing as I'm scrolling down on it?
Yes.
Okay, perfect. Because my screen's not showing that. So cool. So yeah, it has personal and family strengths. So they'll write in here, like, what are my strengths? So then we can build on those, right? But then it talks about who's their family and friends and if they want to work on that. So if, say, they have a lot of family and friends and they can write in there, it's great. Everything's beautiful. Are there any opportunities for growth in that? And if there are, what are your goals to grow in that? So it's a great resource for them to just be aware of, like, oh, yeah, I really do want to enhance my mental health. And how do I want to do that? And then we can set small goals with them. And then it talks about their basic needs. Do they have housing? Do they have food? Do they have transportation, postpartum supplies, breast pumps, whatever it is that they're needing? And if not, do they need it? And then case management, behavioral health, physical health, education. Do they want to go back to school? How empowering is that? That's kind of what I did. I started going to school my first 3 months in recovery. I don't know if that was a good idea or bad idea, but it kept me out of trouble. So, parenting and family supports. Do they have a birth plan? Do they know about safe sleep education? That's a huge topic in the maternal and infant child death review is babies, SIDS or just babies being placed in their cribs in a not safe situation and dying from that. So do they know about this? A lot of my friends sleep with their children, their babies. I'm like, please don't. But yeah, cultural thing too. So, and then my favorite part of this is the partner, which somebody had mentioned earlier, is addressing the partner's needs. I don't know how many times I walked into a hospital setting where the partner is over there sitting in the corner, dope sick. Well, mom is on the bed getting methadone or getting treated for her withdrawal symptoms, and she's feeling fine, but she keeps looking over at dad, who she knows is going to leave any minute to go get high. And she's thinking about that, and she wants to leave, but she just had a baby and she can't leave. And that is so stressful. So oftentimes what I would do is invite that partner to be part of the conversation about their baby, even if they're not the parental person in that space, but they're the person that they brought with them. Do they want to be part of that? Obviously checking with the mom or parent, but inviting them into that space, because just leaving them isolated in the corner is not helpful, I promise. So making sure, and even if we don't necessarily think that they are as supportive as we would like them to be, but they are that support person that they brought into that room with them. So how can we invite them into that space and make it healthier for everyone? I've walked people down to our chemical dependency clinic, the partners, to get on Suboxone right there. Not that it always works out that way. It doesn't. And sometimes they'll leave, and lots of times moms will follow or parents will follow. So just strengthening that whole family unit and it's such a unique opportunity to do that. That we need to take advantage of that situation in more spaces. And like I said, a lot of times there will be intimate partner violence involved in situations, and we might not particularly care for the partner, but we still have to respect their decision and their autonomy over having that person with them in that moment, and that is maybe their only support besides us. So then it talks about who their providers are, their doula, mental health provider, all the people that are on their care plan. And then their support system, somebody that they trust, somebody that they can call on who isn't going to judge them and their information, and then their family wellness plan. Should a crisis occur or a person consider using substances, what is their plan? If they have a plan already set in place, chances are more likely that they're going to actually use it. If they don't have a plan, then they're going to end up going to the hospital in a crisis situation, which isn't always helpful. So if we have, or get child protection called on them. So if they have things in place, like say they want to use drugs and they have a plan of where their children are going to go while they use, then they'll actually use that plan if they have that conversation with the person. And it's someone they trust that isn't going to call on them because they want to do what they want to do, but they're doing it in a responsible way. I've had participants come through our clinic and who were apparently under the influence and had their child, 4-year-old child with them. And I was like, how did they get here? They usually take the bus. So they're kind of incoherent a little bit on and off. And I didn't feel like that was safe for the child, right? So I had to have that conversation. We assessed the mom and made sure that she wasn't at a risk of overdose, which she wasn't, but she was pretty high. And so in those moments, what I did was I checked with my fellow staff to ask them, like, what should we do? I don't want to make a report because I know how hard she's been trying. She's been coming to all our appointments, but she's high today. She just lost, this is the annual date of her, I think her brother that passed, and her partner had just passed like 2 months prior. So the girl was going through a lot. And as empathetic as I am, I wanted to be there for her, but the safety of that child was like overseeing everything that I was trying to like comprehend and assess. So I met with fellow staff and we talked about it. And so I went and had a conversation with her and asked her, how did you get here today? And she said that her dad drove her. And I was like, phew. I was like, hey, do you think your dad would mind coming in and talking to me just for a minute? I just want to check in with him and make sure that like he's got your daughter until, you know, you're feeling better. And that's what happened. And we didn't have to make a call. And she called me a few weeks later and thanked me for being so kind and continued on her path to recovery. And 2 years later, she's still doing great. So I think a lot can be said about how we truly meet people where they're at, and also making sure that we're also covering our own profession at the same time, right? Like if I'm a mandated reporter, which I am, making sure that I'm covering all the bases, but there was no immediate threat of harm to that child because the grandpa was caring for her. So, so providers, their support system and their wellness plan, and then also the referrals that we are going to be giving them. So this is out of Michigan, again, accessible through the slides. So when we talk about our recovery coaching skills in action, there are the relationship, I think, for me, is the most important thing, building that trust, building that understanding of trying to get to know as much as we can about the person in front of us and what is actually going to be helpful. And there is no cookie cutter. There is no, if we do A, B, and C, everything will be great. We have to be innovative in trying to figure out and navigating the system that's really hard to navigate, and hence why they need our help to begin with, because it is scary and fear drives people away from it. And we need people who are pregnant to get the care. They get that care and support, and it has to be judgment free when all possible. And if it's not, then how can we support them in other ways? And then also making sure that we're staying in our role. We are walking alongside them. We're not there to fix everything, but we are there to help them break down those barriers, supporting their autonomy, even when we disagree, if they're going to use, making sure that we're clear about what the outcomes could be, and making sure that they have plans in place for those things. And then understanding all the recovery changes across the stages, and harm reduction plays a role in every single part of anybody that we work with, really, and understanding what that means and how we can bring that in to help save more lives and prevent deaths. And also knowing that our presence matters more than perfect words. I wish I knew this then. I was so nervous walking into the first birthing, the first birth that I attended. And of course, I wish I knew more at that moment, but also like just being there and being present and being able to play some soft music, and when they needed certain things in certain moments to be able to help them navigate, that was was all they really needed. And it was so meaningful to them. And still having conversations about how powerful that was for somebody is really rewarding in this work. So I would like to hear from all of you before I go on. Is there anything that I've said thus far that is like, oh yeah, I'm going to bring that back into my practice or share that with someone?
If I could go.
Yes.
So the national harm reduction, I'm definitely going to bring that back. I actually only work with women who are in recovery, who are pregnant and parenting, fighting to keep their kids out of the hands of DCF and fighting to get their children back from DCF. So once I saw that, I was like, oh yeah, I'm definitely bringing that back, and I'm going to figure out a way because I am the only recovery coach in a 10-bed residential program. So
Wow. That's amazing, Trish. I'm so glad you get to do that work. Where are you at? What state?
Connecticut. So I work for Liberations program. The program's called Families in Recovery.
I'm writing that down just because I want to look up some stuff. Yeah, do perinatal quality collaboratives, are you involved in that there in Connecticut?
As well as like something else I'm going to definitely dive into.
Yeah.
Because it's necessary, it really is.
Yeah, and they're finally talking about it. I'm so excited that it's finally a conversation that is happening. So grateful. And a lot of people doing great work around it. Thanks for sharing.
And
thank you for that.
I had a friend who was at Liberation House, who was pregnant during her pregnancy, and it made all the difference in the world. So thank you so much.
Oh, that's amazing. I see Tina, you have your hand up.
Oh, yes. I was really excited about all the resources and the way you could collaborate the services for those that are pregnant. My girlfriend, and I have one girlfriend is a nurse practitioner, and the other one is an MD. She delivered babies, and we've been doing whole person care. As soon as they come in a certain way, they would refer straight to me, so we would do a warm handover to each other whenever we saw a need, whether the person was struggling with some type of issue. And just to have these resources is so wonderful. And plus, I do protective services, so I'm dually certified as a peer and a therapist. But I take my hat off sometimes when I have to. And then also, I do court responsibility. If they need services, I make sure that if they are in trouble, how to get out of trouble and do that safety plan. But I never had a program to support it. So I wanted to get the information from the person in Michigan so I can integrate the services that we've been doing from an evidence-based approach.
Wow. That's a lot.
Yeah, I don't think that I just came up with this. After 20 years or so, I was going to retire, but I had to refire because people did not have the supports in place. Even though we were doing it, we just didn't know how to identify or help people from a grant perspective. So we were doing it free, free services for women that needed court responsibility to get reunification and plus give them the supports to get back whole again. So we were available, but like I said, I was trying to get her to come on so she can get the resources, but it was too late. But if I can get these PowerPoints and get the contact in Michigan, I would really appreciate it. Michelle, you did such a wonderful job.
Thank you. And yes, you will have access to everything. Travis is going to send out the slides to everyone. And it's going to be in a Canva viewable document, but you can click on any of the slides under where the resources show up to get to them. And if you have any issues, you can always reach out to me. Happy to help you navigate that.
can you put your contact number in? I really appreciate this. This really encouraged me to keep in the game. I was wondering when something was going to come through, and I saw the advertising, and I just said, I'm going to jump on this train.
Wow, thank you. Thank you so much for that. And I did put my email in the chat. Feel free to reach out. And yeah, like I said, there's a lot of good work happening around this. I think that like in certain states, I work with a lot of partners across the states who do this work. If you don't know Raquel Garcia out of Colorado, Hard Beauty, she does amazing work. Elephant Circle, like there's so many ways to get connected into resources that are supportive. And some of the resources that I'm going to share with you in the last couple of slides are kind of summarizing a lot of those too. So I wanted to read too. I think some people put in the chat. Somebody said decades of research has shown no long-term effects on children prenatally exposed to crack. Yep, absolutely. Harm reduction. Tanisha said, I wish all providers would do things like that. The high rate of mortality postpartum and the harm reduction information. And Alicia says, I work at Moms Do Care for Berkshire County in Massachusetts. Our program only services pregnant and postpartum moms in recovery or in active use. Specific office is located in our main hospital, OB-GYN office, and very grateful for the connections and networking we do with all of our doctors and providers and how well they are accepting to our program. Not all agree, and most all are very grateful for our work we do. Yes, those relationships are critical in this space because we cannot do it all. Unless you're like Tina, who does a million things now. It's easy to do all the things because the passion that we have in this space, it bleeds over into so many other things because there's so many barriers. And then we're like, oh, I want to work on that one. I want to work on that one. And I have really tried so hard in the last 2 years to try to focus on the things that I find myself really impactful in making changes and outsourcing all the other things to people who are really strong in those things. And that's really hard to do, I think, for me personally, but it's really important for us to do because burnout's real. The harm reduction toolkits, as I am on our harm reduction coalition by North Iowa area, I am the only peer recovery coach that is in our crisis stabilization facility. And out of that staff that are here on a regular basis, the only staff has any personal background with substance use. This is amazing. And we have pregnant and postpartum gals coming in crisis, and many people are so scared to even talk or ask about their substance use, and sometimes just say, don't do drugs. Iowa is not the greatest OB and postpartum care along with mental health services. So thank you for sharing that. I think there's so many opportunities again. We had contact with all of our mobile outreach units. So when we did lose contact with a parent, especially after their child was taken from them, because they would just kind of disappear, understandably, we would connect with our mobile outreach and have a memorandum of understanding to have conversations about whether or not they're seeing some of our participants out there, just to know that they were okay and like remind them that our services are available and resources and no judgment. But it's really hard to get somebody re-engaged once they've lost their children. And sometimes it never happens. So there's that piece too, making sure we take care of ourselves in that. As we all know, working in this space, we lose some of our friends and peers. It is hard. Grief is real and it affects us all differently, and checking in with ourselves on that too. Okay, and then I'm going to move on to, I already shared our resources. This is just some of our resources that I wanted to highlight. If you go onto our site, you'll see that we have the live domains, downloadable PDF. My friend who created these slides, who didn't want me to say that out loud, made this really cool computer thing that I was like really dorking out about. But yeah, you can scan that QR code to go to our site, and it'll show you some of the trainings that we've done, provided. I was doing some work with ORN, Opioid Response Network. But yeah, so this is some of the resources. The Pregnancy and Substance Use Guide here is the one that is, I think, the national one that was started in New York. Like I said, it's in many other states. If you're interested in having them create one in your community, you can reach out to Joelle and they will help you navigate what that looks like. You can sometimes get grants. I got grant funding to work on ours here in Alaska. So I'm excited about that. I don't know how easy it is to get a grant today, though, with the words harm reduction in it, since our federal government, we can't say those words, but we can work around that and still provide those services without calling it what it is. Because it's so many other things, right? And then Plan of Safe Care is in here. If, when, how, I've talked about a few times. That is a group of advocates and lawyers who are all about reproductive justice. They help from people who are trying to get an abortion to people who are having rights over their own body. There was just a case where a woman had, she had to agree to a C-section, even though she wanted to have her baby naturally. And they took her to court while she was in labor. So she was on a virtual court and it was on TikTok. I was just like, what is happening? But yeah, ultimately she had a C-section. I think it wasn't, and the issue with that is that in hospital settings, a lot of hospitals have protocols where every 3 hours they have to do something to move that birthing process forward. And that becomes dangerous. That is not natural. And that is sometimes leads to other complications like infections and yeah, it's just not natural. So here in Alaska, the hospital here in Sitka, we don't have a lot of births happening all at the same time, so that's really a non-issue. But like I said, if you have history of substance use, you have to go to Anchorage, which is a busier hospital, and you're likely pushed out faster. So, and then the NNPQC is the National Network of Perinatal Quality Collaboratives, and then the CDC. That's where the milestones that I was talking about for a baby up to, I think it goes up to 4 years. 6 years, I don't remember, but really helpful for the parents. And there's an app that they can download on their phone too. And then there's the National Maternal Mental Health Hotline through HRSA, and that is a federally funded program. I call it every once in a while just to make sure that they're still real humans, not robots, and that they are not going to report somebody that I refer to, and that they have resources. I've asked them for resources here specific in Alaska, and they've told me, yeah, we have some national resources. And I was like, okay, well, here's some resources in Alaska. Now you have those for the next person that calls from Alaska. So just like collaborating in small ways, but continuing that. Also with the mandated reporting, sharing with them if, when, how. Because if, when, how has all the captive requirements for healthcare providers to report on certain things and when it is appropriate, when it is not. So these are two projects that we're currently working on here in Alaska. One is the Pregnancy and Substance Use Guide that I keep talking about. We are in phase 2 of that. So we are working with an advisory group who consists of people who are Indigenous, Native, and also have the experience of going through a pregnancy here in Alaska so that they can mold how this is going to look so it is appropriate to our population here in Alaska, because I am not from Alaska and never had a baby here. So we really want to hear from the experts, the people with lived experience. We're paying them for their time and their expertise. And then when we have a kickoff, we're going to pay them for their time for the kickoff launch, hopefully sometime in August or September. And then one of my other favorite things, I have a lot of favorite things, I know, it's ridiculous, but the pilot program that we're working on with ORAU Faces and Voices, the CDC. We are currently in the second course of a 3-course training. It's 10 modules, so each course has 3 or 4 modules within them. And this is something that we've been building over 2 years. Faces and Voices did an interview with me about 2 years ago and asked for my experiences, and I shared some information and shared what works for me and what I'm seeing in our work. And they invited me to be an expert reviewer on this pilot program. So now it's living in a beautiful platform for education. It's available, it will be available free to anybody who wants to take this training. And it's more in depth of what we're talking about today on certain topics, including intimate partner violence or interpersonal violence. So we call it in there, which is a really cool way to say it because it's not always your partner, right? So yeah, that's something we're working on, and I'm really excited to, we just met with our first cohort of the first course and got a lot of good feedback that we can update it and enhance it to make it more easier for people to follow and more relevant to some of the other things that I didn't think about or we didn't think about. And it was not just me, it was a bunch of people with lived experience that were part of this process. So really excited. And then we're going to bring that to Alaska to have it specifically for the culture and demographics here. So some really cool stuff that we get to be part of. And I think I have a half hour for questions. I thought I was running over time, so I was like, yeah, trying to hurry it up. But if anybody wants to ask any questions or go back over anything that I talked about, we got like a half hour. So Rachel, thank you. Thanks, Tanisha. I love what you wrote. Was everybody able to open the document that Travis shared? Anybody have problems with that? Okay. Well, if you do have any issues with it, let us know and we'll make sure that we address those.
And I'll just say, like, if you guys don't have questions, we're not going to hold you hostage for 30 minutes. So feel free to go about your day. Michelle, this was excellent, but I'll hang for a few for those of you who want to stay and ask questions or chat. Just
Yeah,
throwing
if
that out
anybody has
there.
a case or anything that they want to talk about, yeah, just Oh, everybody wants their half hour back. I get it. We are busy people. Yes. Well, thank you all for being here and just sharing some of your work that you get to do, and just willing to learn. I think knowledge is power. The more we know, the better we do. And one of the biggest things that I've learned is that people don't know what they don't know. So when we're working with child protection or courts or whatever, sometimes they just don't know how to address situations, and that could be scary for them, which brings fear, and fear turns into anger. So just trying to hold that space can get us a lot further than just pushing for change in a way that's not productive. Thank you, everyone. I see your kind words.
A lot of love in the chat here, Michelle. Great work.
Thanks. I love it.
Thank you.
Thanks for being here.
All right, I'm going to stop my recording, but we're here for questions. Don't forget, I'll leave that up to you guys.